Hi, everybody. I'm Cindy Braden. I'm the SVP of Sales for EnsoData, and I want to thank you for taking time out of your very busy day to join us for today's webinar, Tips and Tricks to Get a Successful Pediatric Sleep Study. We really like to try to provide these educational opportunities for the people that we work with. So we have a huge thank you to Michael for joining us and putting the content together today. A couple of housekeeping things, and then we'll go ahead and get started. Okay, I want to introduce our speaker. There's quite a bit that I want to say because I think it's really important to know about all of the things that Michael has been involved with. So Michael McLeland, Ph.D. RPSGT, is the Technical Director for the Sleep Center at St. Louis Children's Hospital. He's also the President of the Missouri Sleep Society, Director and Treasurer of the BRPT, and chairs both the Finance and the Pediatric Exam Committee for BRPT. He's been involved in sleep medicine for more than 20 years, and in addition to clinical experience, he's also passionate about sleep research. Probably a reason we like him so much, because we are passionate about research here as well. His current research involvement is examining breathing in premature infants and using high flow as an alternative to PAP. Michael created the first support group for children using PAP and their parents in St. Louis, and he started the Pediatric PAP Clinic. Michael has played an active role in sleep medicine education at both the state and local level. He pioneered and directed both the first accredited sleep technologist education program and COA-PSG accredited AAS degree program in Missouri. I think it's really neat to know about the continuing education that he's providing. He created and taught the Science of Sleep undergraduate course at Washington University in St. Louis. He teaches and works with both physicians and fellows during their pediatric sleep training with the Sleep Medicine Fellowship Program, as well as working with anesthesiologists and their program. And he continues to teach pediatric sleep in the A-STEP program at Washington University School of Medicine and speak to the schools in the St. Louis metro area about the importance of sleep. So you can see why he's very passionate about sleep and the places that he's gone out and made a difference in his own community. And I'm going to hand it over to Michael now to take us through the presentation.
All right, great. So thank you everyone for attending. It's really exciting that a lot of the people that are attending are doing less pediatrics than I thought. I thought it would be kind of half and half, but I'm excited to hopefully share some of my knowledge, and you guys can take it back and use it in your guys' sleep centers. So really the main objectives is to define why knowledge of different pediatric syndromes is important, identify the best practice or best channels in place of others, so kind of like a checks and balance type of system, recognize a challenging patient, discuss the differences between end-tidal and transcutaneous CO2 monitors, and identify and troubleshoot nasal cycling. And then if we have time, we'll kind of do an overview of some common mistakes that I often see in pediatric sleep labs when we're scoring respiratory events. So this is a picture of my sleep lab here at St. Louis Children's Hospital. So I'm not really going to go too in depth of what child-friendly is in a sleep lab. These talks have been done multiple times at different conferences, so I don't want to take up too much of our time. A lot of my time is going to be talking more about the technical end. If you have a good signals coming in, you're going to be able to then have a good study coming out. Scoring tech can end up scoring it quicker. Physician has an easier time in interpreting the data as well. But a couple of key points I want to point out is, especially if adult sleep center is looking into pediatrics as a source of bringing patients into the sleep lab, it's important to make sure that the clinical staff is interested in pediatrics. And if not, then it's important to hire outside, because if they're not interested in doing pediatrics, which some people are not, it will create a better atmosphere for the patient and overall study for both the patient and the parent. Third, parent involvement is very important. They're really the allies of the sleep tech by helping kind of hold their child, even kind of holding their hands, or if they start seeing them start pulling at stuff, they're in the room with the patient versus the tech have to run into the room. So they could have a lot of things off the time the tech gets in. And then room for the parent. So here, I'm gonna turn on my laser pointer here. So here, this is all of our rooms look exactly the same. And we have a couch in the back for a parent, and then we also have the recliner in the room. We do allow both parents to stay in the room. We're solely a pediatric lab, so we do, and we're located right inside of the hospital, so we do a lot of complex patients. Having both parents there kind of helps give them a break where one can sleep and the other one can help us out during the night. And again, policies, I'm not going to go too much into, but it's important to know how you're going to accept your patients, either through a direct referral. Here at St. Louis Children's Hospital, about 75% of our patients are coming in as a direct referral. And then we do this for a few reasons. And one is so we don't create too much of a backlog for the patient. So it's oftentimes to get into a sleep specialist, it could take months, 2 to 6 months to get in just to see the sleep specialist, where our sleep lab right now is about 3 to 4 weeks to get in. So if they can be directly referred to the sleep lab, we will do that. Of course, we look at all the medical records and stuff like that to make sure it's acceptable and we have all the documentation. Of course, having policies in place for your O2, when to start O2, if you have to call a physician versus if the tech or if the patient kind of meets criteria. PAP is a big thing because, of course, we normally don't do split nights on a pediatric patient. We have them come in for a first night, and then if PAP is decided or they've already had a TNA done, then they come back for a second night. But there's a whole process in place. So you should have some type of a sleep educator where they're doing mass fitting with the patient and acclimating them to PAP, and then parent has some education on a PAP tolerance and how to kind of get their child to wear the CPAP mask. And then we schedule them for a sleep study once the parent feels comfortable enough that they think the child's going to wear their PAP mask. And then emergencies is another thing, is making sure you have protocols in place for pediatric emergencies. For instance, here we had this patient come in. He was a 10-year-old patient referred by ENT. No medical history of seizures or any comorbidities, pretty normal child, just enlarged in tonsils and just not getting enough sleep at night. This is EPIC 3, as you can see here, and we get these classic, we're seeing this classic spike and wave form. And as you can see, it's kind of more in the central right region of the brain. So we start seeing this at the beginning. It does go away. This was the only epic that we really saw this on, why the patient was awake. So we didn't really do anything about this. But later on, we did start seeing the spike and wave, more dense throughout the EEG. And so tech did a good job calling the on-call sleep physician, just letting them know that we're seeing this. And looking through the medical record, we didn't see any history of seizures. The problem came was towards the morning. This was around 5:22 a.m. You notice the spike and wave density really increased towards the end of this epic here. And then patient went into a seizure, and we ended up having to call a code. And even by the time the code team came and took him to the emergency room, he was still in this seizure. So tech did everything right. As soon as she saw him start to go into the seizure, she ran in. As you can see, the patient was prone, hurried up, turned him onto his side to make sure in case he vomited, he didn't aspirate, and made sure that he was kind of in the middle of the bed away from all the guardrails. And she started putting them down as well to make sure he didn't injure himself during the seizure. So recently, the BRPT, December 2020, January 2021, finally released the pediatric certificate exam. I was kind of the spearheading this and was in charge of the committee. And we basically did a job task analysis. I had pediatric sleep technologists from all over the country. I had a couple from Australia and a couple from China. We looked at to see what pediatric sleep techs did compared to adult sleep techs, and kind of looked at why it was important to have a pediatric exam. And one is really to differentiate some of the things that we don't really see in the adult side, either because the medical condition patient doesn't survive into the adult world, or the condition isn't as bad when they become adults, so sleep problems aren't as pronounced, and you really don't see them in the adult sleep center. So it's really to ensure those that are new or interested in the pediatric sleep medicine know the different comorbidities that's not usually seen in the adults. And then the challenges also that arise from these different conditions when doing a sleep study. And I'll also help the technologists to kind of predict what is going to be seen on the sleep study when the patient comes in. So there's 4 domains of the exam, but the domain 1 was probably the most important, and it really takes up most of the exam. Most of the questions are on the pediatric sleep disorders and medical conditions, and it takes up about 40% of the exam. So we test over insomnia, hypersomnia, sleep and breathing disorders, parasomnias. A lot of them you're already seeing the adult side, so it's kind of more of a review. These questions are from the RPSGT exam. What we really focused on was more of the sleep and medical disorders and special populations, and then of course circadian rhythm disorders. And this is just taken from the blueprint that we created. These are the different medical disorders that we are testing over. And for instance, like Pierre-Robin syndrome, it kind of encompasses a few things. So it encompasses this microagnathia, where they have kind of a small lower jaw. But also too, majority of these Pierre-Robin syndrome patients also have a cleft palate. So there's those things that you think about. So like in our sleep lab, we do a lot of sleep testing on these Pierre-Robin patients when they're in the NICU, when they're just born. We do a pre-test because plastic surgery wants to kind of gauge on how severe their sleep apnea is. And so we'll do a test, and then they go in for surgery, and then they have what we call a jaw distraction, where they kind of push the jaw forward, and then they keep adjusting this after surgery. There's screws on each side that they keep adjusting until they think they're at kind of the optimal point, where we do another post-sleep study on these patients. Another big population of ours is Down syndrome. So basically, kind of what we do here at Children's is these different medical disorders. We have a huge binder of all these sleep disorders or medical disorders, and the sleep techs at night are really good about kind of documenting things in this binder of what they're seeing and what kind of problems that they run into. And it's really good for especially new staff coming on. They can kind of pull this binder. If they see a patient that has Pierre-Robin, they can look at it and see kind of in the past what the sleep technologists had seen in the sleep study, and kind of the hookup problems and kind of troubleshooting. So just kind of a kind of an educational tool that we use a lot. But anyways, so kind of sidetrack. Down syndrome patients. So just like every other patient that we know, they're going to have obstructive, majority of them are going to have obstructive sleep apnea. They have a larger tongue, smaller jaw. But what we noticed during a sleep study on Down syndrome kids, especially they do when they're sleeping. A lot of times they will sit kind of crisscross, and then they sit forward to sleep. So that's some of the things that we have seen. And then also, like looking at sickle cell disease, it's not so much that they have sleep apnea, but when we don't do very many sleep studies on these patients, but when we do, we get a long baseline because we want to see what their oximetry is doing before they fall asleep. Just remember, when the sickle cell, the red blood cell is kind of a sickle shape, so it can't carry as much oxygen. So it's normal for us to see their SpO2s in the mid to upper 80s. But it kind of gives us a baseline, so when they do fall asleep, we can kind of see what their, kind of estimate what their saturations are going to do. Another one is like a Chiari malformation. And basically, a Chiari malformation involves the cerebellum and the medulla. The cerebellum is really responsible for voluntary movements. The medulla is the main responsibility of breathing. And then some of the symptoms that people with Chiari malformation will have is problems with vision, problems with breathing, especially central sleep apnea. They'll have numbness in their extremities, and they'll also have syncope, which is dizziness. And why this is important to know is because when a lot of times we get patients that are already kind of diagnosed with Chiari malformation. So the sleep technologist is going to know that night that this patient is going to have probably more central sleep apnea than a normal child. But what basically happens is a couple types of the malformation is the back of the skull, which is this here where I'm highlighting, is kind of pressing against the cerebellum and the medulla, and which is causing the central apneas and the other symptoms as well. Or there's the other type, which is the cerebellum and the medulla is kind of being pushed down into the spinal column. So what happens is then these patients will, if their sleep apnea or central sleep apnea is bad enough, neurosurgery will go in and remove that section of the skull in the back to relieve that pressure and create an opening for the medulla and the cerebellum. Again, here's another example here where the back of the skull is being removed. And again, so we'll do a pre-test, and a lot of times we'll do then a post-test, and we'll see a significant decrease in their central apneas. But oftentimes those patients are coming in without a diagnosis of Chiari malformation, but there are times where we've been able to diagnose Chiari malformation after a sleep study. Usually here, if the central apnea index is greater than 5, we will recommend that an MRI is done to see if the child has a Chiari malformation, if there is no other past medical histories that would warrant central sleep apnea. So a typical sleep montage in pediatrics is kind of like the adult, but like I said before, it's kind of like a checks and balance system, because kids are a lot more difficult, and especially during these confusional arousals, they don't know really what's going on, and they're just pulling and tugging at everything. So there are checks and balances within, or it should be a checks and balance within the sleep montage. So we have your typical eyes, your chins, your EEGs. The Academy recommends only looking at the F3, C, or F4, C4, and O2. We have them all up at all times, just because if one goes out, we can delete it and keep going. We don't have to go in and fix it or anything like that, or pull it up into the montage. We have legs, snore mic, and all that. Some of the differences is that we use is the sum channel and the intercostals, and these two things we'll discuss further. The pulse wave form is, or the pleth for the pulse oximeter is important as well. It kind of tells you if your the readings that you're getting for your oximetry is correct or not. And then you have your end title, because for pediatrics, we have to have end title or CO2 monitoring on all patients, but also the end title waveform. So the waveform is important too. It's kind of like a pleth for the oximeter. We can tell if we're getting an accurate reading in our end title by looking at the pleth. And then the transcontinuous. And then I'll go towards the last part of my talk, I'll talk about the difference between the pros and cons of the end title versus transcontinuous. So why more channels? Like I said, it basically creates a kind of a checks and balance system. It helps within the hookup process because we can hook up most of the channels. The two channels are the two things that are the most difficult on any pediatric patient, no matter if they're what kind of medical conditions they may have, is the thermistor and the cannula for the PTAF and end title. I would say about 60–65% of the time we're not able to get, or we're about 30–35% of the time we're not able to get a thermistor and the cannula on the child. But at the time of hookup, but then once the patient falls asleep, the technologist can go in and sometimes get them on. If not, then we can run without them by using that sum channel. But again, this kind of creates more of a patient comfort and kind of get to our goal of getting that patient to sleep. And then it gives in the middle of the study, it gives the sleep technologist kind of an opportune time to kind of wait for if something falls off. We can wait until the patient wakes up to go fix something because we have something else that we can rely on. And it also helps limit the amount of times that they're going in and out of that room. So we'll talk about the sum channel. The sum channel is calibrated, and usually it's produced by some kind of a module, such as these. There's several different companies that make it. The hardest part is we use a lot of we use all disposables here in children's. One, it's more cost effective because if a child was to kind of pull, first thing they reach for is that nasocanial and that thermistor, and they pull and usually are breaking the wires. So we can just throw that away, get a new one, put it on, and go on. So the belts we try to use as disposable as well. That way we don't have to worry about washing and making sure we're meeting all the risks and stuff like that with washing them. So we ended up going with this one here. It's just because the disposables and it's easy to fit to each individual patient because of the belt. So here's an example. Here our PTAF is out. We have a really good thermistor, and we have a good sum. So the sum channel is basically being derived through that module. It's kind of a mathematical equation that creates a waveform. So basically what you have is two inputs, which is your chest and your abdomen belt going into the module, and then three outputs, which is your chest, abdomen, and then your sum channels. So this sum channel is really good at helping you identify hypopneas. So here in this example, we don't have a really good PTAF flow. And you can kind of see a decrease in your thermistor, but this doesn't always happen. Remember, a thermistor is only picking up temperature, fluctuations in temperature, not fluctuation of flow. So most normally you would kind of miss hypopneas when you're just scoring off your thermistor. But if you have this backup, the sum channel, you could see exactly when it starts, which is here. Notice that we see a decrease and a flattening of your sum channel. And here we have the 4% desaturation. Again, here's just another example. There is a 4% desaturation on my next slide here. It goes to 91. And then here's another good example here. Here, yeah, we would probably mark these as hypopneas, but physicians here at Children's really want to know the length of each respiratory event. They want it measured correctly. So this kind of helps us gauge a little bit more on the length of each respiratory event. And then here's just an example. There's no respiratory event, but we do have a desaturation. You'll be surprised on how many techs will find a respiratory event somewhere around here just because they kind of see this desaturation and feel like that there should be something causing it. Another thing that the sum is really good at helping you identify the respiratory event is essential sleep apnea. Basically, if you have no flow in your chest or abdomen belts, you're not going to have a flow coming out the mouth, right? So easy to pick up. What the sum channel will not, or most of the time will not pick up, is an apnea, obstructive apnea. This patient here, during the arousal, you can kind of see the thermistors working and the PTAFs working. But notice when there's should be no flow, there is movement. So what will happen is you're going to overscore hypopneas versus the obstructive apneas. In the long run, it doesn't really matter per se, because if they're coming in for surgery, for a TNA, it's going to be treated the same if it's obstructive apnea versus a hypopnea. During a PAP titration, it doesn't matter because you're getting your flow through the CPAP. But we do use this the sum too, because sometimes if the leak starts to get high, or we can't control the leak, sometimes that CPAP flow is questionable. You can rely on your sum. So during a CPAP titration, it's fine because you're going to increase your pressures the same if it's a hypopnea versus an apnea. It comes into play when you have a BiPAP titration and you're increasing your IPAP for hypopneas and then your EPAP for obstructive apneas. But your sum channel is only as good as both belts. So notice here, our chest, we have a lot of just poor quality. So even if one of the belt is poor, your sum signals are going to be poor as well. So that's something to keep in mind. I'm kind of excited about the intercostal channel because the ASM finally put in the 2.6 scoring manual. They put the intercostal channel back in, not as a not that you have to have it, but as a backup for effort. And it's really easy to use. There's no special equipment. It's really minimal cost. You can use 2, 3, or 4 extra electrodes, and they're just placed between the ribs on the intercostal muscles. And I recommend anywhere between T5 to T8, in between those ribs. If the patient is obese, you can always kind of go for more the side instead of the front, but make sure you're always putting them on the left. If you put them on the left, or if you put them on the left, you get more EKG artifact. So I recommend the right. And if you still can't really feel the ribs, you can always go to the back, because obese patients kind of most of the time will carry their weight up front more than they do the back. And this is a really good example of the intercostal channel here. And you can see with every effort, there's increased density of this kind of like a leg movement type of channel. So here is an example of why I really like the intercostal muscles, because in the past, if you weren't using this channel, majority of everybody would have scored this as a central apnea, right? You have flattening of your thermistor, you have no flow channel, but you have your pretty much flattening of your chest and abdomen as well. But here we're seeing effort throughout these darker, more intense areas of the channel. So this is obstructive apnea. And for some reason in pediatrics, we see this quite often where we just see this, not a building of the respiratory effort, but more of just almost flattening, kind of like what we're seeing here in this example. Again, here's another one. Here we would, again, in the past, mark this as a central apnea, but with this intercostal channel, we can say for certain it's obstructive apnea. And then here, kind of our belts aren't good. We're getting kind of poor quality, but we can definitely say this would be an obstructive apnea because we are seeing effort here and effort here, versus here we're essential apnea. We don't see that effort until here. Just some more examples here. Just the length of the central apnea was a little bit too long. It actually should have stopped right about here. And then here's a central apnea as well. We have no effort, but you do have effort before and after. All right, I'm just going to take a couple seconds to pause here and have you guys look at this epic and kind of see if you guys know what the problem is here. All right, I don't know if anybody guessed, but it's the oximetry. So notice the oximeter is reading 100. This is 90 seconds, and it only dips down to 99 once. And notice the pleth is flat. If you're not looking at the pleth, majority of the time people are just going to let this go. And then, of course, you can't. This isn't an accurate study. The oximetry should always fluctuate, even if they're not having any respiratory events. It should be hitting 99, 98, at least a few points during this 90-second epic. So this is one reason why you always want to have the pleth showing on your sleep study, even on the adult side, but more so on the pediatric side because they're always tossing and turning. So you don't know when those two sensors that are supposed to be above or by, on each side of each other can shift just a little bit, giving you an accurate reading of your oximetry. So basically, like I said, it helps determine if the oximeter is reading accurately. And there's several reasons why this can be poor. It could be a bad oximeter, even as simple as the tape too tight around the finger that's holding the oximeter could be a problem. So when you're doing your BioCals, it's really important not just to look at the channels that you're doing the calibrations on, but to also look at every channel to see you're getting a good recording. And the pleth should be one of those channels during BioCals that you're looking at. Here's another example where it's a poor pleth. So this whole 2-minute screen here should be really marked as artifact. These spikes in oximetry is poor. And notice towards the end, there's really no fluctuation of your pulse ox. And you have these spikes as well towards the end. So this whole thing should have been marked as an artifact. Some more artifact here. We have the spikes, and there's arousal. So it's expected to have some artifact within that arousal. But notice after this arousal, you kind of have this almost mimics the breathing pattern. So false, and the patient could be kind of laying on their hand or have their hand up behind their head, causing this breathing artifact. And then notice towards the end, notice the change in the oximeter. This is artifact as well. So this whole 2-minute screen should have been marked as artifact as well. Here's more of this breathing artifact that we're seeing in the oximeter. So we cannot rely on this, on the readings at all. Another thing most sleep systems now have is kind of a plot that as the study is running, We use neon codon, so this is what neon codon, so we can look at this plot as the study is recording, and it will kind of give us a picture of what's going on as well. And notice the patient here, so light blue is below 90%, the blue and darker blue is above 90%. Here, the patient's having continuous respiratory events. So we would see desaturations from 90 to into the 80s. But here, once the patient's out of REM in stage 2, stage 3 sleep, and here the patient's all below 90%. This should be another trigger to know that the oximeter is not reading correctly. Our policy is if we see a patient down below 90% anytime during the study, the sleep tech needs to go in and verify this with a portable pulse oximetry. And then they document what the portable was reading, so we can gauge if it's accurate or not. But then it helps the sleep tech too to know, well, if it's not reading right, I'm going to have to do some troubleshooting. So again, this is a great picture of what is going on in the moment, besides just looking at the pleth. But you can tell this pleth, there's no waxing and waning. I'll show you here in a moment. This is what your pleth should look like. You should see this waxing and waning movement as the patient's saturations increase and decrease. So we know this is good just by looking at the pleth. So again, we should be doing this before hookup, or we really should be before lights out when we're doing our biocals and troubleshooting throughout the night, because we don't have a backup to a pulse oximetry. So it's important that it's reading correctly, especially to identify respiratory events. All right, so nasal cycling, and people just don't think about it as much as we should, especially in pediatrics. We know it's a normal phenomenon. Most everyone has this. Basically, what happens is this congestion alternates every 4 to 6 hours from nostril to nostril. And you could do it now and plug one nostril and try to breathe, and then plug the other one and then try to breathe. And you can see you can breathe better through one than the other. It's basically the body's response to warm and humidify the air as we breathe. And basically what's happening is the nasal turbinates are on one side get engulfed with blood, kind of warm, so it can warm the air. And then, like I said, it alternates. You'll hear even adults say, well, I can't lay on my left side, because laying down makes it worse. So if it's the left side and they're trying to lay down on their left side, the pillow kind of pushes against the sinus cavity and the nair, and they can't lay on their left side, so they'll turn and lay on their right side. So what we see with this nasal cycling is, in pediatrics, you have to run some type of CO2 monitoring. Most pediatric labs will do end-tidal CO2. And because of that, there has to be a cannula that's split. So in a normal adult, you just do the PTAF, you just have a cannula that has just one output. With pediatrics, we have to have one output that goes to the PTAF, and then one to the end-tidal. And so what happens is the nasal cannula itself is split. So one side will go to the end-tidal and the other side will go through the PTAF. We do use the nasal oral cannula, but the oral part, even with mouth breathing, isn't very good picking up any of the samples that we need. Because again, both of them are being picked up through one small tube instead of each nostril. So either we're going to get low readings or a poor flow, or really no readings and poor flow, depending on how bad the nasal cycling is. Sometimes it will block the nair completely. And I'll kind of discuss what I've seen done, and then what should be done. So here is a same patient through the next few slides. Here, the start of the study, we have no end tidal waveform. The tech is in there quite often, changing out the cannula, recalibrating the end tidal wave or the end tidal machine. They're also trying to unplug the cannula, thinking it was plugged, but finally gives up for a while. And notice here the end tidal is starting to come back a little bit, and you can tell this by the readings here. Instead of reading 0, now we have 9, 10. So we're getting some movement through that other nostril. Also notice the flow, or the PTAF, is starting to degrade in signal. So we're starting to see more of a decrease in the PTAF and also flattening. And then a few minutes or a while later, now we have complete sensation of the flow, and we have a good end tidal waveform, and then we have good readings. And all the while, the tech now is back in there trying to fix. They're changing out the PTAF and the cannula and doing all that. But what they ended up doing was actually putting 2 cannulas that was designated for each, for one for the PTAF and one solely for the end tidal, which I do not recommend that. You're just blocking the nares even more. But what we do here is we do both transcutaneous and end tidal at the same time. So if this ever happens, we have transcutaneous to kind of back us up. So CO2 monitoring, I'm going to talk about the pros and cons of end tidal and transcutaneous. So the pros of end tidal, it's really a lot cheaper to use. They're about $4,000 a piece. The nasal cannulas are pennies on the dollar. Filters are cheap and stuff like that. So it's really cheap to use. And it's easy to use. You basically turn it on, put the cannula on, and go. Usually having to recalibrate it maybe once a month or so. It's breath to breath, so you're going to see more changes within the values. You have a plus signal to know that you're actually getting the signal that the values that you want. The pros of the transcutaneous is you can use it during a titration. Patient tolerance is very high. Basically, it's a little sticker that houses a plastic unit that the sensor snaps into. Some of the cons of the end tidal, it can't be used during the titration, and this is even stated in the scoring manual. And then, of course, you have nasal cycling, so you may not get a signal for a while. Again, if they are a huge mouth breather, the signal just doesn't come through the oral part as well. There can oftentimes be obstruction in the tubing, because remember, we're getting breath by breath, and our breath's humidified and moisture. So we could, and if the kid is crying at all during the night or during the hookup, and can cause obstruction within the tubing itself. Patient tolerance is very low. Like I said, the thermistor and the PTAF are the 2 hardest things to get on pediatric patients, no matter if they're a normal patient versus a Down syndrome patient or a patient with autism. And then the end tidal also becomes unreliable if there's back-to-back central apneas or obstructive apneas, because basically there's no breath coming out, so there's nothing to sample. So some of the cons of the transcutaneous, they're very expensive. They're about twice as much as an end tidal. They cost twice as much to upkeep them. The sensor itself is very fragile, so we abuse them in pediatrics because of the patient's tossing and turning. So they're always constantly pulling it, and and breaking them. Recalibration often happens a lot during the night. Transcutaneous has a tend to kind of creep up for no reason. So we have to go in, recalibrate it, and then put it back on the patient. And then it'll go back down to kind of where they were or where they should be. But again, there's no way to really visual see if the transcutaneous is picking up correctly or not. And this is kind of a learning curve for sleep technologists getting used to transcutaneous, when to know if that value is real or not. And then of course, if there's any type of sweat, if the patient was really worked up during the hookup, or if they have severe sleep disorder breathing, and they start sweating, you create that salt block between the patient and the sensor, so you're not going to get a good reading. And that kind of leads into the poor contact, but not only sweat and the salt block, but also with them tossing and turning, that sticker starts to peel away, and then the sensor starts losing contact that way as well. There's also a longer reaction time to see any changes within the transcutaneous CO2. And I should mention too, most of our pediatric sleep labs are using Smith's Medical entitled transcutaneous CO2s, and we are scrambling to find replacements because the company is no longer making the water trap for the machine, so they're no longer servicing the machines as well. I'm currently working with Smith's Medical to find kind of a workaround until they can find another manufacturer for the water trap. And I'll give you my contact information if any of you guys are using the Smith's Medicals and running into that situation. I can tell you what we're doing and what we're trying to validate what we're doing using the Smith Medical. So here we're looking at the end-tidal waveform. Here again, it's kind of our pleth to make sure that we're getting good readings, and it's poor, and we know this too by the readings that it's giving us. Here the waveforms down here on the bottom, not the best signal as well, because you really should see a plateau in your signal. So how reliable this is, I wouldn't rely on it too much, but it is pretty close to our transcutaneous monitor as well. And I'll show you here. So it's kind of skewed by the PTAF flow, but the channel is flattening, and I have a better example here at the bottom. And we really should see this plateau with every breath. This is the machine. The machine is actually pulls the breath into the machine to give a sample. And that's one reason why you can't use the end-tidal waveform as a backup to a PTAF, because it's not their true pressure, because the machine is actually drawing in the sample, not the patient breathing into the machine for the machine to analyze the sample. And then this was just an example of how the end-tidal is almost a breath to breath. Here we're seeing decreases right away, where here the transcutaneous is still at 46 when the end-tidal is reading 31, 33. And then interesting enough, the patient does start to drift into the 50s with the end-tidal. The transcutaneous is still sitting there at 46 for quite a few epochs. And then here, and it's not until the end that the transcutaneous is finally going to go up in the 50s. Interesting enough, a few more epochs later, the end-tidal is down, and now the transcutaneous is reading 50, 60, and then tech is going to have to go in and recalibrate it because it's kind of drifting higher than what we've seen in the end-tidal. So the importance of CO2 monitoring in pediatrics is because diagnosing of obstructive sleep apnea can be done with just CO2 monitoring alone, along with a sleep study. So in the ICS D, third edition. If we have 25% of total sleep time with greater than 50, with association of one or more of the following: snoring, flattening of the nasal pressure waveform, or paradoxical effort, that child could be diagnosed with obstructive sleep apnea. And I kind of left this for last, common scoring mistakes. I'll kind of briefly go through so we have some, so I can answer some questions. So we'll have a couple minutes here. I'm not going to go over the definitions of pediatric rules. Just know the main difference is 2 missed breaths instead of 10 seconds. And central versus obstructive is just basically central has none of the, no snoring, no flattening, no paradoxical breathing. What we see most common is overscoring of hypopneas. Again, we see this desaturation, which is good. We have this arousal, but this, yes, this is a decrease in your PTAF channel, but only from the arousal. Remember, you need to look at or try to recall what the baseline breathing or pre-event breathing would look like. So this is really his normal breathing here after this arousal. When he's back to his pre-event breathing, there is really none. You shouldn't compare what's going on during the arousal. It should be before the arousal. So no obstructive hypopnea there. Again, here is no hypopnea here. This would be kind of questionable. It could be either way. 30% decrease in pressure because you have your arousal there. I'm going to go through these. Central apnea, really the only difference between pediatric and adults is if you do not have the 3% hour arousal, it has to be at least 20 seconds long. Under the 1 year of age, this is really, I've only seen it once since I've been in pediatrics, so it's really rare to see. But what we see a lot of times is is marking them wrong. Like this one here is, we have that 3% desaturation, but we do not have the 2 missed breaths. That's only, say, 1. Or they kind of score through quickly and they'll score this as an obstructive apnea instead of a central. Really the only thing I want to pick out here is in pediatrics, there's actually 2 ways a mixed apnea can happen. It could start like the adult. You can have the apnea first and then, or the central first and the apnea second. But in pediatrics, you can actually have the obstructive apnea first and then the central apnea second. Hypnagogic hypersynchrony is often scored as arousals. Here, I just kind of wanted to show the difference. Arousal, 99% of the time, you're going to have artifact within all the channels during an arousal. With the hypersynchrony, you're not. You're going to have kind of this almost delta activity that kind of bunched together. Another example here, this is really good of identification of HH's arousal. Again, you have really artifact throughout all your channels. All right, so I'd like to thank all my staff. Of course, they've been great and they're really good with our patients and really have been great in our expansion as well. So here's my email address. Please, if you have any questions, don't hesitate to contact me or reach out to me, especially about the Smith medicals and entitle units. I can kind of discuss what we're doing.
We did have a couple questions pop up. I will try to get through them quickly, and nobody laugh if I say things incorrectly because I'm clearly not a tech, but does the SUM or SUM channel help in detecting paradoxical breathing pattern?
It does not, no. So I can go back quick. So here, This is a good example of paradoxical breathing here. Notice it does nothing to the sum channel. Again, we see what we would call hypopnea if we didn't have these two other channels to be able to reference, but no, it will not do anything to your sum.
Perfect. Next question, do you have a recommended filter sensitivity setting for the intercostal channel?
Yep, just like you do your legs, the 10 and 100.
And then, oh, we did have a couple more pop up. How do your techs score events following a sigh?
Interesting, yeah, that's one of the things that Dr. Kemp, who is kind of in a semi-retirement phase and doing research on the prevent and preemies. Majority of the time, they do have a central after the size, but we only score them again if they meet the criteria of the rules. We would score it as a respiratory event.
Okay, that was it. Michael, thank you so much. I know here at Enso, we were very much looking forward to this because this is just a bunch of really neat information that I think most technicians don't get a chance to get a ton of experience with. So anyway, that's fantastic for you to put this together. I can't imagine the time and the effort that you put in. You can tell it's something that you're very passionate about. So we really appreciate you taking time to share with the rest of us.
Yes, yeah, yeah, because sleep studies are so expensive and quality is very important.
Yeah, right. Getting the right outcomes for these patients, especially the little buggers that are that are coming into your lab. So awesome. Thanks so much, Michael. Thanks so much, everybody. Have a great day.